Hello and welcome to this episode of What the FFICM. Today we're going to be talking about necrotizing fasciitis. So what is necrotizing fasciitis? Well, it's a progressive, fulminant and life-threatening bacterial infection of the subcutaneous tissue. It can affect any part of the body and it's caused by an infection of the deep fascia and subcutaneous tissues. So your skin is composed of two layers. The superficial one is the epidermis and underneath this is the dermis. The dermis contains blood vessels, hair follicles and sweat glands. Below the dermis is the superficial fascia, followed by the subcutaneous fat, then the deep fascia, and finally the muscle. So both these fascia, the fat and the muscle, make up the subcutaneous tissues. And this is the site of infection in necrotizing fasciitis. This is in contrast to cellulitis, which originates at the junction of the superficial fascia and the dermis. Fournier's gangrene is an eponymous name which refers to necrotizing fasciitis of the perineal, perianal and genital regions. So what's going on during a necrotizing fasciitis infection? Well, initially, microbes enter the skin via traumatic breaks on the surface of the skin, or due to direct spread from perforated bowel or the urogenital tract. Organisms then release exotoxins, endotoxins and enzymes which cause tissue damage and allow the rapid spread of infection through the fascial planes. Exotoxins are secreted by bacteria and cause damage by destroying cells or disrupting normal cellular metabolism. Endotoxins are predominantly lipopolysaccharides which are found on the outer membrane of gram-negative bacteria. They act as a superantigen and cause widespread activation of the immune system. The end result is microcirculatory failure and intravascular thrombosis, causing localized necrosis and ultimately skin ischemia. So how is necrotizing fasciitis classified? Well, there are 4 classifications based on the causative microorganism. Type 1 is polymicrobial. This is the most common and causes 70 to 80% of cases. Type 2 is caused by group A Streptococcus plus or minus Staphylococcus aureus, and this is the second most common, accounting for 20 to 30%. Type 3 is gram-negative monomicrobial, and this is rare. And type 4 is fungal, and this is also rare. So in terms of type 1, tissue samples taken from patients with this condition typically identify on average 4 different organisms. This is usually a combination of gram-positive cocci, gram-negative rods, and anaerobes. It occurs most commonly in the perineal region and the trunk, and it's often associated with immunocompromise or risk factors, which we'll discuss later. In terms of type 2, this most commonly occurs in the extremities or the trunk. It can also be associated with toxic shock syndrome, and it usually occurs in immunocompetent young patients. In terms of type 3, this is most commonly Vibrio species, and these are associated with water contamination. Type 3 has a very high mortality, around 30 to 40%, even without appropriate treatment. And finally, fungal necrotizing fasciitis most commonly occurs in traumatic wounds and the burns of immunocompromised patients. And this has an even higher mortality, approaching 50%. So what are the risk factors for necrotizing fasciitis? Well, we can break these down into nutrition, comorbidities, skin integrity, and miscellaneous. In terms of nutrition, risk factors include obesity and malnutrition. When thinking about comorbidities, the risk factors are immunocompromise, diabetes, peripheral vascular disease, and malignancy. In terms of skin integrity, blunt or penetrating trauma is a risk, as is intravenous drug use. Burns, as we've already mentioned. And thinking about miscellaneous risk factors, well, advanced age is a risk factor, as is childbirth. So how does necrotizing fasciitis present? Well, the first thing to say is that it is a surgical emergency, and it requires prompt recognition and intervention to reduce the mortality associated with this condition. The rate of progression is variable, but it can progress extremely rapidly, with multi-organ failure and death occurring within hours of presentation in some cases if it's left untreated. The clinical features can be thought of as occurring in 3 stages. Firstly, there is erythema of the skin with associated pain, and this pain is disproportionate to the clinical findings. The patient may also have generalised symptoms such as nausea, vomiting, malaise or diarrhoea, and there may or may not be a history of trauma with damage to the skin. In stage 2, skin bullae and blisters start to form, and there's evidence of skin ischemia. And finally, in stage 3, hemorrhagic bullae form. There is crepitus due to gas produced by organisms underneath the skin. There is skin necrosis, and ultimately multi-organ failure. We've already said that necrotizing fasciitis requires prompt recognition and treatment. So how do we investigate this condition? Well, it is essentially a clinical diagnosis, and it's important to say that investigations should not delay the time to surgical exploration and tissue biopsy. The diagnosis is often confirmed at the time of surgery, with evidence of fascial and muscle necrosis, loss of fascial integrity, and the tissue loses all resistance to blunt dissection, with very little blood loss occurring at the time. There is also classically the presence of foul-smelling dishwater pus. However, the reality is most patients will receive some initial investigations when they first arrive at hospital. So these would include blood tests, such as a full blood count, a coagulation screen, urine electrolytes, LFTs, CRP and calcium, lactate and glucose, and an arterial blood gas. Results you might expect to find include a raised white cell count, a thrombocytopenia and an anemia, a coagulopathy caused by DIC, acute kidney injury, hyponatremia, a raised CRP, hypocalcemia due to chelation of calcium within the necrotic tissue, a raised lactate resulting in a metabolic acidosis, and a raised glucose due to the physiological stress response. Microbiological investigations are obviously important, and these include peripheral blood cultures and, crucially, a tissue biopsy at the time of surgery. Both of these should be sent for gram stain, microscopy, culture and sensitivity. Blood cultures are positive in up to 60% of Group A strep infections. And if there's any concern about fungal necrotizing fasciitis, then samples should be sent specifically for fungal culture. And lastly, we'll think about imaging when it comes to necrotizing fasciitis. Now, it's really important to say that imaging should never delay surgical exploration. However, with the increasingly widespread use of CT scans, early features of necrotizing fasciitis may be seen in scans which are undertaken if an alternative diagnosis is suspected. Features you might see include deep fascial thickening and enhancement, and fluid and gas in soft tissue planes. Now, there's a risk score for necrotizing fasciitis called the Laboratory Risk Indicator for Necrotizing Fasciitis, and this helps distinguish the condition from other soft tissue infections. A score of more than 6 has a positive predictive value of 92% and a negative predictive value of over 96%. Now, the risk score includes measurements of CRP, white cell count, hemoglobin, sodium, creatinine and glucose. These are all blood tests that you would expect as part of a routine set of admission bloods for a patient presenting to hospital with a possible infection, and the results are usually available fairly quickly. We've already said that necrotizing fasciitis requires prompt treatment, and importantly it also requires prompt management to reduce mortality. Patients can present in severe septic shock and multi-organ failure. And so your initial assessment should follow an A to E pattern with treatment of any abnormalities as they are discovered. The principles of management are firstly aggressive resuscitation, followed by early surgical exploration and debridement, treatment with broad-spectrum antibiotics, intensive care admission and supportive care, and possibly the use of treatment adjuncts such as intravenous immunoglobulin or hyperbaric oxygen therapy. In terms of aggressive resuscitation, patients will require IV fluids to restore their intravascular volume, and it's likely that they will also need the early initiation of vasopressors to overcome vasoplegia, and this should be done according to the surviving sepsis guidelines. The aim is to maintain adequate tissue perfusion and oxygenation. Resuscitation is required to help stabilise the patient and optimise their condition. However, definitive treatment is with early surgical exploration and debridement. Debridement removes the source of infection and toxins. However, it might be that the debridement required is extensive. This can include limb amputation or resection of large areas of skin and muscle. Patients usually require multiple debridements to ensure adequate control of infection, and these often take place anywhere between 12 and 48 hours apart. The consequence is that patients may be left with large open wounds, and in order to manage these, surgeons might use vacuum dressings or quite extensive packing. The input of a specialist tissue viability team can be very beneficial in the management and surveillance of these large open wounds, and insensible fluid and protein losses should be taken into account. Regular dressings and wound packing is required, and there should be close surveillance for secondary infection. Patients with Fournier's gangrene may also require defunctioning colostomy, either due to anal sphincter involvement or to facilitate fecal diversion and prevent ongoing wound contamination. The next mainstay of treatment are broad-spectrum antibiotics. These should be administered within 1 hour presentation, and so the first dose is usually given prior to surgery. Initial treatment is with a broad-spectrum agent such as piperacillin tazobactam, and if group A streptococcus is suspected, clindamycin should be added to switch off toxin production. Specialist microbiological input is essential, and the results of blood cultures and tissue culture will aid the rationalisation of antibiotics. It's important to say that antibiotics will not penetrate necrotic tissue, and so adequate surgical debridement is crucial to ensure their effectiveness. Most patients following surgery will require admission to the intensive care unit, usually due to ongoing septic shock and/or the presence of multi-organ failure. As part of this, they should receive adequate nutritional support, including early enteral nutrition, and there should be close surveillance for an early treatment of nosocomial infections or secondary wound infections. There are some potential adjunct therapies for necrotizing fasciitis. These include intravenous immunoglobulin. There's limited evidence for this treatment, but expert opinion supports its use in confirmed group A streptococcal infection or in staphylococcal toxic shock syndrome. Intravenous immunoglobulin binds to endotoxins. It also induces antibodies against exotoxins. It prevents complement activation, and it promotes the phagocytosis of bacteria. Another adjunct therapy is hyperbaric oxygen therapy. This helps switch off toxin production in anaerobic infections, particularly those involving Clostridium species. However, there is very little evidence for hyperbaric oxygen in other causes of necrotizing fasciitis. And from a practical point of view, the majority of hospitals do not have access to hyperbaric oxygen, especially for patients receiving intensive care support. Necrotizing fasciitis is an extremely serious condition, and its mortality is approximately 25%. In patients who do survive, they often require a long period of rehabilitation, and this is due to the results of life-changing surgical debridement and often a prolonged intensive care stay. Patients may require several reconstructive surgery procedures, but these should not be undertaken until all infection has been eradicated. So in summary, necrotizing fasciitis is a life-threatening bacterial infection of the deep fascia and subcutaneous tissues. There are 4 types of necrotizing fasciitis based on the microbiological cause. Type 1 or polymicrobial is the most common, particularly in patients with risk factors. Prompt recognition and early surgical debridement are both crucial in helping to improve patient outcomes and reduce mortality. Importantly, investigations and imaging should not delay surgical exploration. And management includes aggressive resuscitation, early surgical debridement, broad-spectrum antibiotics, and intensive care admission. Thank you very much for listening to this episode of What the FFICM. Check out the description below for some further suggested reading, and if you have any questions, please pop them in the comments section. If you found this video useful, please hit the like button to help others find it, and why not subscribe to our channel? If you turn on notifications, you'll receive an update each time a new video becomes available. Thanks again for listening, and we'll see you next time.